If we relate this now to the abnormal situation, here we have an expanding hematoma. The blood is collecting. And as this blood collects here in the left cerebral hemisphere, we're going to start getting localizing signs on the right hand side of the body. So there could be motor weakness developing on the right hand side of the body because we've got a left hematoma. That's what tells us what side of the cranial cavity it's on. So as the hematoma increases in size, as we've noticed, it can push across the midline of the brain. So first of all, we'll get expansion of the hematoma, causing our localizing signs. Then we'll get shift in the midline of the brain. But also, as well as pressure going across here, pressure is deflected down the way towards the tentorium. And to begin with, the tentorium can withhold that pressure. As the pressure increases, the tentorium will not give way. But then eventually, part of the temporal lobe will be pushed down through the tentorium. This is called tentorial herniation. Remember, a hernia is tissue pushed into a place where that tissue should not be, where it goes into another body cavity or indeed goes out of the body, but here into another body cavity. So here part of the temporal lobe has been pushed by the pressure of the hematoma through the tentorium. Now we've got part of the temporal lobe that has been moved, pushed down or herniated into the infratentorial space from the supratentorial space. This means we have a mass of tissue now in the infratentorial space which should not be there. It is herniated through. Can you see that that will quickly increase the pressure in the infratentorial areas of the brain? And this will certainly give rise to Cushing type effects, because remember, the vasomotor centre and the cardiac centre and the respiratory centre, of course, are located in the medulla oblongata of the brain stem. But as well as that, because the pressure here has been increased, so first of all it's the pressure there, then that happens next, then that pressure moves down to there, so there's increased in pressure now in the fourth thing, increased pressure in the infratentorial space. This is now going to push on other tissues in the infratentorial space. And what happens is the increased pressure, fifthly, pushes some of the cerebellum down out of the hole at the base of the skull, which is called the foramen magnum. And this means that the brain stem, particularly the medulla oblongata, is now compressed. And of course, as well as compressing the medulla oblongata itself, the herniated area of the cerebellum, there as a result of the tentorial herniation, is going to compress the blood vessels which supply the medulla with blood. They're going to be compressed, and the medulla will lose its blood supply and it will lose its oxygen supply. When this happens, the patient dies essentially instantly. This is called coning, because if you look at the situation in post-mortem, you see that the tissues have been pushed down into a cone-shaped, compressed into a cone-shaped area. And once coning occurs, we have no treatment to offer. This patient will always die, unfortunately. So the sixth thing that happens there is the coning. So obviously, the earlier in this chain of events that we can detect the pathology, the better, and the greater the likelihood that we can correct the underlying pathology without extended and significant and life-threatening neurological damage. Let's look at this idea of coning from the perspective of the inside of the cranial vault. Here we see the back of the skull where the cerebellum would sit in life, and that the brainstem would sit in that area just there, above the foramen magnum, which is this hole, of course. And the tentorial membrane is going across this part. So down here is the infratentorial cavity, and above this is the supratentorial cavity. And if the tentorial membrane across here gives way, then part of the temporal lobe is going to be pushed down into the infratentorial cavity. And that's going to push on the cerebellum. And I'm going to illustrate the cerebellum with a piece of paper. So imagine my fingers there are the brain stem. If part of the cerebellum is pushed down through the foramen magnum, like that, it's going to jam in that tight little hole there, relatively little hole. And that's going to compress my fingers, i.e. it's going to compress the brain stem. And that basically is what coning is.